The following podcast is part of a certified educational activity titled Toward Functional Cure in Chronic HBV, Monitoring Serological Markers and Evolving Therapy. Access the entire activity and complete the post-test at peerview.com/QKQ860. Downloadable slides and practice aids are also available.
Good afternoon. And again, thank you so much for joining us at the liver meeting, and welcome to our CME program here, Toward Functional Cure in Chronic Hepatitis B Monitoring, Serological Markers, and Evolving Therapy. I'm Dr. Paul Kuo from Stanford, and I'm delighted to be joined by my co-panelists, Dr. Tatiana Kushner from Cornell. Our goals for today during the symposium, we're going to learn about comprehensive HBV serologic testing, including the use of an emerging assay, quantitative hepatitis B surface antigen, how it can better guide and personalize treatment decisions. We're going to learn about ongoing monitoring of disease progression, liver complications, and treatment response, and how it is essential to optimize long-term outcomes, and also discuss an evidence-based, goal-directed treatment plans that are key to advancing patients toward the ultimate goal, which, as we enter this new era, is functional cure. So I'm going to start now with the discussion about the role for serological markers in determining optimal monitoring and treatment course for chronic hepatitis B. So this audience is well versed in the epidemiology and burden of chronic hepatitis B in the United States. Prevalence, it has been somewhat challenging to estimate, but up to 2.4 million individuals chronically infected. Greater than half are of Asian, Pacific Islander, or African descent. One of the challenges we face is that only a quarter of individuals are diagnosed, and the rates are higher in men, and this contributes to significant health disparities. Moreover, within the U.S., still thousands die annually from chronic hepatitis B, and again, this is something we need better efforts towards screening. And indeed, in 2023, the CDC screening recommendations for hepatitis B were revised, and they're shown here. And now, again, we went from risk-based screening to universal screening, and the CDC recommended screening all adults greater than aged 18 years of age at least one time. This was clearly simpler and is what is done for virtually all infectious disease done for hepatitis C. In addition, screening all pregnant people during each pregnancy for hepatitis B surface antigen, preferably in the first trimester. And again, those with ongoing susceptibilities, risk factors, need to be tested periodically regardless of age, while the risk for exposures persists. And how do we test these individuals? So they recommended a triple panel for hepatitis B. And this includes the surface antigen, which we're going to discuss extensively, the antibody to the surface antigen, as well as the core antibody. And with these, you can use and tailor your follow-up based on the results of the tests that are resulted here. And this is just a cartoon of the hepatitis B life cycle, and why this is important is because this really highlights the challenges of trying to treat hepatitis B. And so we know hepatitis B, it enters here, the cell here, to the NTCP receptor, binds, enters, and then goes to the nucleus where you have this formation using host polymerases of the CCC DNA. You transcribe here, revert, and then you generate your RNA, which goes here to be translated into your proteins. You have this encapsulation, reverse transcriptase. This is where our nucleoside therapies have worked for decades. And you generate new viral progeny. There's some recycling, and then, of course, there's virion secretion here. And again, because hepatitis B is a virus that goes through this complex replication process as a double-stranded DNA virus, it's very hard to design therapies that actually lead to functional cure. We can suppress the virus, and we've been able to do that for decades effectively, but effecting functional cure is something that is coming on the horizon, but has been a significant challenge in the treatment of this disease. And so as we look to the natural history of hepatitis B, surface antigen is playing an increasingly important role in the natural history of chronic hepatitis B. So the presence of hepatitis B that you get in your serologic testing and when you order your tests, it complements the quantitative HBV DNA that we obtain as well. There's a risk factor gradient just like there is for hepatitis B DNA for the development of hepatocellular carcinoma, one of the feared complications of chronic hepatitis B. Surface antigen clearance is a highly desirable treatment endpoint. With our new therapies that are increasing the rates of hepatitis B, or they're not so new anymore, but our nucleoside therapies which suppress HBV DNA so effectively, the effect of these nucleosides and nucleotides on surface antigen has not been as significant, and thus we are now having emerging therapies we'll hear about that can actually clear surface antigen. And when this happens, there's an improvement in survival, lower rates of hepatocellular carcinoma and liver decompensation. And again, there are spontaneous and nucleoside-nucleotide analog-induced surface antigen clearances that do occur, not at a high enough rate though, and the rates have been estimated anywhere from 0.5% to 2% annually. And so here's just a snapshot of what quantitative surface antigens look like in the natural history of hepatitis B. And so you have 4 populations on this cell, and these are individuals. So you have the immune tolerant or immune trained individuals at the top in green, and you can see here that the surface antigen levels are quite high. As you trend toward an immune clearance phase, you can see the surface antigen levels tend to decline some. And in a low replicative phase hepatitis B, you can see that the surface antigen levels in general are significantly lower. And these are individuals who are e antigen negative in general. And you can see also in the bottom right here in orange here, e antigen negative. Again, you can have a gradient here, but by and large, the surface antigen levels are lower and significantly lower than they are in the immune tolerant individuals. We take advantage of these quantitative levels, and over the years there's been accumulation of studies looking to see if we can use this quantitative threshold to design strategies that allow us to stopping nucleoside analogs or NAs. And this was a very nice study that was the RETRACT-B study. And what they did was they looked at long-term outcomes after stopping nucleoside analogs. And you can see here the results show that after discontinuation up to 48 months here, you can see the overall cumulative loss of surface antigen was about 13%. And when you looked at this predicted loss, you could see there were 2 groups that nicely were falling out from the data. So Caucasians with a surface antigen level less than 1,000, actually they had reasonable surface antigen clearance rates. Asians, it was less than 100. And you can see here that these individuals could safely stop NA with a reasonable opportunity to clear surface antigen. However, again, you have to be careful here. You can see here in the bottom left graph, there were significant rates of decompensation, particularly in those with cirrhosis. And this was a further analysis that showed that this threshold in the RETRACT-B paper of 100, when you looked at an even lower threshold, less than 40, you can see here that the cumulative virological relapse rates were even lower than they were when they were between 40 and 100, and maybe even lower levels are should be considered. The new 2025 AASLD guidance was released earlier this week, and so I put here in lavender, you can see here the updated guidance, and the AASLD is now recommending against stopping nucleotide analogs in adults with chronic hepatitis B or e antigen negative without cirrhosis, with sustained undetectable HBV DNA. And so now the time to consider for the new guidance withdrawing NA therapy is now when you have achieved surface antigen loss. And again, quantitative surface antigen at the end of treatment is still the best available biomarker to predict outcomes after nucleotide analog withdrawal. Lower quantitative surface antigens, regardless of the recommendations, are linked to higher likelihood of surface antigen loss or functional cure and clinical relapse. And less than 100, again, is considered a conservative threshold, but caution should be adapted here. And again, the updated AASLD guidance, which will be presented, by the way, on November 9th in Hall A. This is something that we're all going to have to learn with. For now, the guidance is written such that we should continue NA therapy now until your surface antigen has cleared. The quantitative surface antigen is available and approved in the United States. According to the prior guidance, these were some of the potential applications here. They included identification of inactive carriers, those who in general have quantitative surface antigen levels less than 1,000 international units. It was also identified as a tool in those who receive PEG interferon. A lack of a decline can certainly serve as a stopping rule or a futility rule for those who are PEG interferon candidates. And finally, a decline if you start NA therapy is actually also something that can be a useful function as well. If you start in NA therapy, if you have an early decline, this increases the likelihood that you'll be able to later achieve a low surface antigen level with a low chance of relapse. There are a few quant surface antigen posters and functional cure presentations here, and here are some of the various abstracts that you can visit. We're going to now stop after that introduction, and we're going to hear from Dr. Kushner, who is Associate Professor of Medicine, directs the Outcomes Clinical Research at Weill Cornell, and thank you so much.
Thank you so much, Paul. That was really excellent. So now moving to actually our approach to chronic HBV antiviral therapy, both now and in the hopefully not too distant future. So how might we think about changing our practice based on newly updated guidance as well as our look to the future? So to start, set the stage, I think we need to all recall, and we're all very aware of the goals of therapy for hepatitis B infection. We want liver histology improvement, we want serum HBV decline, ALT normalization, and ideally seroconversion, which means loss of E antigen positivity, production of E antibody, and most importantly, loss of surface antigen, what Paul was discussing, or functional cure. But ultimately, the goal here is improved clinical outcomes, and we know that all of these are surrogate markers that prevent improved clinical outcomes, and we want to prevent cirrhosis, hepatocellular carcinoma, and death. And we've learned a lot about the viral life cycle of hepatitis B. We've already heard a bit from Paul, but really there are specific milestones that we look at when we treat individuals, or even in the natural history of hepatitis B, that we really hope to achieve in order to have the most durable viral response and improvement in overall clinical outcomes. And that really starts on the left here from hepatitis B DNA decline. Then we have E antigen seroconversion, HBV DNA decrease to undetectable levels, and then clearance of surface antigen or functional cure. And most ambitious would be clearance of CCC DNA, which, as we've heard from Paul, is a very ambitious goal that we're working towards but have not quite gotten there yet, but hopefully in the future. Why aim for functional cure for chronic hepatitis B? Well, there are potential advantages of clearing surface antigen versus long-term suppressive therapy, and we list some of these important considerations. In terms of specific medication-related effects, so we can avoid risks of long-term nucleoside-nucleotide analog therapy by having a finite duration of treatment and functional cure, reduce costs associated with long-term lifelong therapy, avoid risks of hepatitis B flare with discontinuation of nuke therapy, which our patients often worry about, reduce risk of reactivation years after treatment stops, so for example in settings of immunosuppression, but most importantly to improve overall clinical outcomes, and also very importantly to reduce stigma. So some would say we have nuke therapy, why not just take it long-term, but many patients are not very enthusiastic about being on a long-term therapy that also is associated with stigma that reminds them of their condition on a daily basis. So what is the current landscape? Who are we recommending to treat with our currently available guidance and the updated guidance from earlier this week? So this is fresh off the presses. This is the new 2025 AASLD IDSA treatment guidance in those with chronic hepatitis B who are E antigen positive without cirrhosis. So first I'll draw your attention to the green box here, which is the clear category where we are recommending treatment. And this is completely unchanged from the 2018 AASLD hepatitis B guidelines. Anyone who is E antigen positive, has a viral load over 20,000 and ALT over 2 times the upper limit of normal, these are the immune active individuals who we recommend without question should be treated. Then if we look to the orange box here, this is the immune tolerant group. So these are the individuals who have very high viral load but normal ALT. And for many years, we really thought of this group as someone that we don't routinely recommend treatment. But the current guidance say that there are certain aspects of these individuals that should increase your likelihood to treat. And we've learned that individuals over age 40, as well as, of course, those who are now already showing signs of fibrosis, those are individuals that you should consider treating. For individuals under 40 years, use shared decision making to discuss the risks and benefits of treatment. And then the green and rather the blue and purple boxes are these indeterminate groups or gray zone groups where, again, you can look at age over 40 and presence of fibrosis to help guide your treatment decision. So it's not just the viral load and the ALT level. You also should be looking at the whole picture of age as well as development of fibrosis. Now, moving to the E antigen negative population, this is the majority of the patients that you're probably seeing in your practices. And again, the green box is the very clear recommendation, as was before, viral load over 2,000, ALT 2 times upper limit of normal, immune active, recommend treatment. Then those individuals who have low viral load, less than 2,000, ALT completely normal, those are the individuals that, of course, you continue to monitor, but you don't need to initiate treatment on. And then again, the middle blue and purple boxes that there's consideration for shared decision making when individuals don't quite meet either of these categories, and you can consider treatment. And again, thinking about certain risk factors associated with increased HCC risk, such as greater age and sex, platelets less than 180,000, are factors that you should weigh in your consideration for treatment in these patients. And I think that the shared decision making approach is really emphasized in the new guidance. And we have been doing this in our clinical practice, but now it's clearly written in guidance that this should be a conversation with your patients if they're in the gray zone about whether treatment should be initiated. So 2 out of the 6 PICO questions included in the guidance specifically say you should do shared decision making. So PICO question 2 in the new guidance says that for persons who are surface antigen positive with viremia, not meeting disease-specific treatment indications, and who are in high-risk scenarios for transmission to others, AASLD suggests shared decision-making approach, bringing in the idea of also not just individual treatment goals, but community and transmission aspects that can influence your recommendation to treat. PICO question 4, in adults with surface antigen positive, E antigen negative chronic hepatitis B without cirrhosis and in the indeterminate phase, AASLD suggests antiviral therapy using a shared decision-making approach. So really having the conversations with your patient, looking at the different risk factors and making a decision that's not strictly based on just the viral load and ALT. All right, so what is the current landscape of treatments that we have available, and should treatment criteria be expanded? And so there has been increasing attention to this concept in recent years, and the reason that we're considering the importance of expanding our treatment recommendation is there's been a growing focus in the field on the importance of viral integration and genetic dysregulation in chronic hepatitis B that happens increasingly with longer duration of disease. And there's a link between these mechanisms and oncogenesis. So we are more thoughtful about the importance of making an intervention to decrease the risk of this oncogenesis, relevance to early events in the natural history of chronic hepatitis B, and the emerging importance, despite highly effective nucleoside-nucleotide analog therapies with excellent safety profiles. So really the evolving perspective on treatment of chronic hepatitis B is thought of whether to treat chronic hepatitis B as an inflammatory disease, in which therapy should be based on liver inflammation and fibrosis, or as a viral infection independent of indices of inflammation and fibrosis, where the integration and oncogenesis really becomes very relevant. So I'll share a few studies that address this aspect. So this study, published a few years ago, looks at the importance of a duration of treatment with antiviral therapy and the influence of antiviral therapy on HBV DNA integrations, which in turn is correlated with hepatocyte clone size. And in this study, where individuals were treated up to 10 years, they saw that people who were treated for longer durations of treatment had a reduction in hepatocyte clone size and a reduction over time in HBV DNA integrations. And that suggests that even with our current therapies, that longer duration of treatment and earlier initiation of treatment can be beneficial from the HCC perspective. This is another study that looked at a 3-year interval of tenofovir treatment, and they saw that clearly a 3-year interval of tenofovir disoproxil fumarate treatment was associated with a decrease in HBV integration compared to individuals who are not treated. So this kind of thought process is really what has led to experts saying that perhaps we should really be thinking more broadly about hepatitis B treatment, and perhaps we should be starting earlier, because the longer that there is viremia that is not being addressed, the more likely is there to be integration and risk for HCC. And that has led to a few other guidance documents that have been published that this is a simplified treatment algorithm for hepatitis B care, and it was published by Doug Dietrich and colleagues. And it said, we need to think about this more simply. Let's treat everyone who is at least age 30, who have HBV DNA over 2,000, and treat them with our currently available therapies. And yes, you can still defer treatment in those who are under 30 years old, but really thinking about just looking at the viral load, ALT over upper limit of normal, and starting at age 30. There was also another expert opinion published on looking at expanding treatment criteria. And in this expert opinion that was published by Iyer Jacobson and Dr. Su, looked at actually not even looking at the age 30 cutoff, but simply looking at whether the individual has a viral load over 2,000 and ALT over upper limit of normal, then those individuals you treat. So simplifying and expanding our treatment approaches. All right, so what are the available treatment options? Well, it's quite simple. We don't have too many different options. We have entecavir, we have tenofovir alafenamide, and we have tenofovir disoproxil fumarate. And TDF has been used also in combination with emtricitabine, but rarely in practice do we use it. Generally speaking, and the updated guidance clearly states that these are our main treatment options that are available to us. Now, we've talked a lot about treatment, but when can treatment be stopped? Paul already commented on this, and this is just a little bit more detail from the updated guidance. So in certain settings, some may use pegylated interferon, and in that setting, it is a defined duration of treatment of 12 months. So those individuals can stop treatment at that defined duration. People with cirrhosis, we do not stop treatment. So really, people with cirrhosis, we should continue lifelong treatment. Now, in people with on nucleoside-nucleotide analogs, as Paul mentioned, the guidance clearly says we do not recommend stopping unless there's surface antigen loss. However, they also say that there is a shared decision-making approach that can be also used here. So in those individuals who are really hoping to stop treatment and you are having that conversation with them, if they meet all of the following criteria, that gives you a little bit reassurance about stopping treatment. And here you see that there is a mention of quantitative surface antigen level less than 100, as Paul was speaking to us about. Obviously, they should have no advanced fibrosis or hepatic decompensation, and they should have no co-infection with HIV or Delta. and they should be willing to adhere to frequent monitoring after stopping. So if you are stopping treatment, the guidance clearly states that you need to monitor these patients very closely, and if their viral load goes up, reinitiate nuke therapy to prevent decompensation. So where are we going in the future? We have, as Paul already showed, the viral life cycle. In the viral life cycle, multiple potential targets to work towards functional cure with chronic hepatitis B, and they're shown here. So we have an entry inhibitor called bulevirtide. This is being studied more in delta hepatitis, but again, also stops viral entry for hepatitis B, of course. We have nukes that we already mentioned that work here. And then we have CCC DNA silencing, which is our ultimate goal, but we're not quite there yet. And there has been a lot of attention actually at this part of the viral cycle where we can inhibit protein translation using siRNAs or ASOs, and I'll talk a little bit more about that. So why are we studying these approaches and how do they work and how do they differ? So we have siRNAs and we have antisense oligonucleotides. And what they do is they degrade the hepatitis B mRNAs to prevent translation into the key proteins for hepatitis B, namely hepatitis B surface antigen. And they work in slightly different ways, but both of them at that same key part of the viral life cycle. And on the right, you see some differences in terms of their structure and how they are implemented clinically. So siRNA is double-stranded, ASO single-stranded. The dosing is a bit different. siRNAs are every 4 to 8 weeks, ASOs more frequently every week. siRNAs and ASOs have some immunologic activity, but more so on the ASO side, where it stimulates TLR activity. And clinically speaking, they may be associated with ALT flares. And most importantly, in terms of why we're using them, is that they can promote surface antigen decline and ideally surface antigen clearance. So what is the data? Well, this is a study that was published now a few years ago in the New England Journal of Medicine looking at efficacy and safety of bepirovirsen, or we call it Bepi, in people with chronic hepatitis B. This was the first study to demonstrate increase in functional cure rate over interferon or nucleoside-nucleotide analogs. And this was a study that looked at Bepi, 300 milligrams, and looking at initiation at different times and also comparing to lower dose of Bepi, and then looking at functional cure rates 24 weeks after treatment cessation. So this is off treatment response. And what they looked at is individuals who had different levels of quantitative surface antigen, which is why this is a recurring theme, to see whether we can actually decrease the surface antigen levels. And what they saw in this study is that 9% of individuals who started with receiving nucleoside-nucleotide analogs and 10% not on nukes actually achieved functional cure. And then also what we learned from this study is that quantitative surface antigen levels are very important in predicting who responds to these types of therapies. So those individuals with quantitative surface antigen of less than or equal to 3,000 was a strong predictor of response and functional cure. And an update about Bepi, it was granted fast track status in February 2024, and there are 2 phase 3 studies that are now ongoing with estimated completion in late 2025. So this is a very, very exciting update in the hepatitis B field, where we have phase 3 studies that are anticipated to be completed later this year, and hopefully we'll see the approval, finally, of an agent that is showing efficacy with functional cure. So very exciting times. In terms of safety, obviously also a very important consideration. Overall, it was well tolerated. Few serious adverse events were reported. The main adverse events of interest were, of course, injection site reactions, because this is an injection, and also some reports of thrombocytopenia and ALT flares. There are a few abstracts at this conference that are being presented, but just to show that we're really working on figuring out how is BEPI working in terms of its effect on immunologic responses, how can it work in combination with other agents such as pegylated interferon and sequential therapy. And so still a lot more to learn, but we are moving the needle forward, and it's reflected here in the abstract at this meeting. Now, another agent that I wanted to quickly mention is an siRNA. This is elnesiran, and it was a study called the Piranga study, phase 2 study, also published in the New England Journal. And I think what's important here is that in this study, this siRNA was combined with immunomodulator therapy. One arm had rosutolumab, which is a TLR7 agonist, and then another arm, the one in purple, was in combination with pegylated interferon. And we're running a little bit short on time, but in this study, what they found is that 23 of the patients in the arm where they had combination with pegylated interferon had surface antigen loss, again, 24 weeks after end of treatment. So this is also impressive numbers, although I think we have to be thoughtful about the future in terms of how we're going to combine these agents, and also if pegylated interferon, which we were hoping to kind of move on from, will actually still be a backbone of some of the combination therapies. And the last thing I'll say is that we're excited about the BEPI update and the studies that we're seeing, but I think there's an understanding in the field that really in the future what we'll be looking at is combination therapy, where we'll have agents that are directly antiviral in combination with immunologic therapies, and it's this kind of combination therapy that will hopefully lead to better outcomes. So I'll turn it back to Paul to talk about treatment outcomes and disease progression. Thank you.
Thank you very much. We're going to now talk, just as he said, we're going to about monitoring treatment outcomes. So the long-term complications of chronic hepatitis B, why we treat. And it is because of these outcomes that we are trying to avoid with therapies, and they include fibrosis, progressing to cirrhosis, and hepatocellular carcinoma. And again, hepatitis B, like MASLD, is one of the unique diseases where you don't have to have cirrhosis to develop hepatocellular carcinoma. So here are some of the factors that increase the risk for hepatocellular carcinoma in the setting of hepatitis B. And again, cirrhosis from any cause, obviously including hepatitis B, increases the risk. But again, age, sex, alcohol use, smoking, you can see here, obesity, steatosis, family history, aflatoxin exposure, high DNA levels. There was a question about the DNA threshold of 2,000 international units. This comes from the REVEAL study, but hepatitis B is our carcinogen, and it is classified as such. Genotype C, co-infections with C and D. And so when we look at the prognosis of those who have been diagnosed or have a diagnosis of hepatocellular carcinoma, there has been some progress in the past 15 years, but the overall prognosis still remains poor. Overall 5-year survival rate, approximately 21%, and largely because of individuals who are presenting at a late stage when they're diagnosed with hepatocellular carcinoma. This is a particularly significant problem worldwide, where screening for hepatocellular carcinoma is not widely available. And again, this is a very famous study from Taiwan, the REVEAL study, and this was the study that looked at the risk of hepatocellular carcinoma in the setting of chronic hepatitis B and showed that there was this biological gradient. And you can see here, it goes from left to right, that the cumulative incidence of hepatocellular carcinoma goes up with the viral level. And again, this helps inform our treatment decisions. Suppressing the virus with our current nucleoside analog therapies is one of the most effective ways to reduce the risk of hepatocellular carcinoma, as is affecting functional cure. Now, one of the important aspects of chronic hepatitis B that we do want to address here is fibrosis assessment in those with chronic hepatitis B. Again, liver biopsy is the gold standard for detecting fibrosis, but it's invasive, and in this audience, I'm relatively certain that very few of us biopsy our patients who have chronic hepatitis B anymore. And so patients do need, when they come to you, some type of fibrosis assessment. And there are numerous methods here, and we show you some serum biomarkers as well as some imaging tests as well. You can use very simple tests derived from laboratory testing you get in the clinic, the APRI or the FIB4. There are also more commercially available tests. There's a fibro test here and a few other scores here. And of course, imaging is widely available in the US and widely available in other parts of the world as well, particularly elastography. And there is also magnetic resonance imaging as well as shear wave elastography. Those are probably not as widely available, but you should have some assessment of fibrosis in your patients with chronic hepatitis B, because fibrosis is yet another reason to consider therapy for hepatitis B. Let's drill down on the hepatocellular carcinoma risk in those with chronic hepatitis B. So this was a multi-center analysis of proportion of patients who developed hepatocellular carcinoma, and these were individuals who were outside of societal treatment recommendations. So you can see here the three major liver societies here, AASLD, EASL, and APOSL. And look at the proportion of individuals outside of treatment criteria. You can see they range from a low in the EASL criteria, 34%, up to 64% of those in the APOSL criteria. And what this means is that a large proportion of patients who develop hepatocellular carcinoma don't meet current guideline criteria for antiviral therapy. And remember, antiviral therapy to suppress virus is one of the major interventions that we have to reduce the risk of hepatocellular carcinoma. And indeed, this was shown in this report here by Huang and colleagues here, and they looked at antiviral therapy in 855 patients without advanced fibrosis at 14 international centers. You can see here that they used inverse probability of treatment weighting to balance these cohorts to treated and untreated patients here. And what they showed was that if you were treated over a 15-year period, that you had a lower cumulative rate of hepatocellular carcinoma than you did if you remained untreated. And the higher incidence of HCC was observed in men, those greater than age 35, e-antigen positive, and those with high HBV DNA levels greater than 1,000 international units. We've been talking quite a bit about hepatitis B surface antigen, and this is going to be an increasingly important biomarker for us to track. This shows that surface antigen loss with nucleoside-nucleotide treatment decreases the hepatocellular carcinoma risk. So you have here two graphs. You have a graph showing hepatic events. This can be decompensation, and then you have hepatocellular carcinoma risk. And you can see here that if you're DNA positive, that you have the highest rate of hepatic events in hepatocellular carcinoma. If you're HBV DNA negative, then your rate is significantly lower. But if you are surface antigen negative as well, you've cleared surface antigen, your risks of hepatic events and hepatocellular carcinoma are the lowest amongst the three groups. So it's important then that our at-risk patients are appropriately screened for hepatocellular carcinoma. And why is this? This is because if you screen, you can intervene more successfully in patients and offer them more potentially curative treatment options. And this was really nicely shown in this trial in Shanghai, China. Greater than 18,000 individuals with chronic viral hepatitis, mostly hepatitis B, were randomized to screening or control, and you can see here that those who were screened were more likely to have their hepatocellular carcinoma diagnosed at an earlier stage, that means stage 1, than those who did not have screening. And you can see here the screen group, 60% had stage 1, the control group, you can see here the majority of them were stage 2 and stage 3 cancers. So screening does work. There are, of course, challenges with this. Here is, again, additional data just showing the impact of screening on survival after the diagnosis of hepatocellular carcinoma. And you can see here over a 5-year period in the screening group, you can see here 46% of people were, with hepatitis B were still alive after their diagnosis, whereas in the control group, the survival rate at 5 years was essentially nil. And so screening does have a survival effect after the diagnosis. The 2025 AASLD guidance for HCC surveillance, these are shown here, and this has now been amended some with the new hepatitis B guidance. Again, We screen those who have cirrhosis, chronic hepatitis B. That's not in any way controversial. Transplant eligible child Pew C patients can also be screened. If you're from an endemic country greater than age 40, women, endemic country greater than age 50, persons from Africa at an earlier age as soon as age 20. If you have a family history of hepatocellular carcinoma, PAGE score greater than 10, HBV, HDV co-infection, all persons, same for the HBV, HIV co-infection here, men greater than 18 years of age, and then, excuse me, all persons with cirrhosis. The most interesting aspect of all of this, though, was a very practical recommendation that has now occurred. And these are individuals who have cleared surface antigen. And again, we get asked this question all the time in clinic, and the new guidance actually addresses this. So if you've cleared surface antigen and you're a man greater than age 40, you still should retain your screening. For women, it's greater than age 50. And of course, those with a family history of hepatocellular carcinoma. And the screening is with ultrasound and AFP every 6 months is the most effective screening regimen. And again, this comes from our 2023 AASLD HCC guidance. So what to do with these tests? This comes from the 2023 AASLD HCC guidance here. So you will see at many centers, our center, we'll find out if Dr. Kushner's center is the same, they report the quality visualization score with the ultrasound. And so if you have a visualization score A with no lesions on the ultrasound and AFP is normal, you repeat the AFP and ultrasound every 6 months. If the visualization score is B, or a lesion less than 1 centimeter on ultrasound and AFP are seen in the alpha beta protein as normal, you need a serial ultrasound. This can be done at a 3 to 6 month interval and AFP in 6 months. And if stable, you repeat the ultrasound every 3 to 6 months and the AFP every 6 months. If you see growth of a lesion, then you need to transition to multi-phase diagnostic contrast enhanced MR or CT scan and subsequent follow-up. Again, we diagnose hepatocellular carcinomas based on imaging criteria with dynamic imaging, not with biopsy. If you have a visualization score of C with no lesion on the ultrasound, you can consider a repeat ultrasound. Sometimes the patient has forgotten and they ate and the intestines is floating up in front of the liver, but you can either try and repeat the ultrasound, but if you do get poor visualization, then you should transition to contrast-enhanced MR or multiphasic CT for these lesions. And if you do see a lesion greater than 1 centimeter or AFP greater than 20, or if AFP is increasing, you should transition to a contrast-enhanced multiphasic MR or CT scan with subsequent follow-up. What about monitoring patients who are not treated? Liver panel every 12 weeks. This I do just for the first year, just to make sure that you're not catching somebody who's going in and out of phases. Same thing for the HBV DNA level. E-antigen and anti-HBe for the E-antigen positive, they can be checked once a year. Surface antigen, again, can be tested every 6 to 12 months in patients who are E-antigen negative with persistently undetectable HBV DNA by PCR. And again, you screen your appropriate populations for hepatocellular carcinoma. Should you choose to initiate therapy, again, a liver panel every 12 weeks for the first year. Again, this is accompanied by an HBV DNA level. Again, the drugs that we use, nucleoside analogs, are highly effective. You're doing this mainly for compliance. You can check the e-antigen annually, and the surface antigen typically on an annual basis as well. You should look for this because it's rare, but people do clear surface antigen, although be it not at a high enough rate. And again, if you're on a therapy such as tenofovir disoproxil, you should also be testing for renal side effects, and this is serum creatinine as well as phosphate and urine glucose and protein at least annually. So to just summarize, and we have one more slide after this, the role of quant surface antigen is evolving as it becomes increasingly recognized as a valuable tool for both prognosis as well as assessing treatment response, guiding treatment decisions, especially with emerging therapies, and over time we'll all become much more comfortable with the management of patients and the use of quantitative surface antigen. The goal of functional cure in hepatitis B is to achieve surface antigen seroclearance, better clinical outcomes, sustained viral suppression, and a reduced risk of liver-related complications, including cirrhosis and hepatocellular carcinoma. And as Tatiana has nicely showed us, new therapies are in development, and you can see the horizon is closer. We are getting closer to functional cure therapies that we will be able to offer our patients. HCC surveillance is recommended in all patients with with chronic hepatitis B and cirrhosis, as well as other selected populations. And when you screen, it's ultrasound and AFP every 6 months based on our AASLD guidance. I am just going to add one more new part from the guidance here, which was if you do have a nucleotide-nucleotide analog suboptimal response, which is defined as a plateau, less than a 1 log decline in the past 6 months, or a breakthrough, or a slow decline, then importantly, confirm adherence. And this is going to be the explanation the majority of the time. They're not taking their medicines. And this can be even highly functioning software engineers who are, you tell them, hey, it's really strange that your viral level is not going down. They come back 3 to 6 months later, it's a miracle. The viral level has declined, okay? But there are some people who don't respond. The additions of medicines you can see here, if you're on entecavir, you can either switch to tenofovir disoproxil or tenofovir alafenamide, or add on depending on the clinical situation. If you're on TDF, tenofovir disoproxil, then you can add switch to TAF or entecavir, or add on entecavir. And if you're on TAF, you add entecavir here. We essentially nobody should be on lamivudine or adefovir at this particular point. And again, you can monitor after the change. You should be checking HBV DNA levels every 12 weeks or every 3 months. We are now completing this. We have many questions. Tatiana, why don't you lead us, and we will try and get to as many of these questions as we can.
The first question you alluded to, but maybe just to reemphasize the point. So one person asks, how to follow patients who seroconverted by themselves after years of being chronic hepatitis B carrier. So someone who converted from surface antigen positive to now surface antigen negative after years, what would you tell them about what kind of follow-up is needed? And really a big question here to your last component is HCC screening, right? That's the main thing that we're doing. Would you say you don't need it? Do you need
so it depends on the age, right? So if someone cleared in their 20s, and you know that, you go back and they have, I typically look at them, make sure the liver profile is normal, and I will even do a elastography study just to make sure they didn't have advanced fibrosis. But if we have a document, and some people have records, then they're fine. They don't have anything other than you educate about reactivation.
Right, right. So the new guidelines actually clearly state that the timing of surface antigen clearance is important to determine whether you need to continue HCC screening. So if men cleared over age 40 and women cleared their surface antigen over age 50, the new guidance says that you do actually continue HCC screening in those individuals who cleared late because they're still at risk for HCC. Another question came in about testing patients who will be receiving chemo. Which test is best to do before instituting therapy?
Yeah. So when we counsel patients who come in, and this can be chemotherapies, but this can be immune therapies as well. And again, there's a proliferation of these agents out there now. So we have to be more cognizant of this. We still check the triple panel. So this means surface antigen, surface antibody, and core. And again, we will, if you're core antibody, most of the time you can monitor. You don't have to prophylax, but if you're surface antigen positive, then you need to put these people, for the vast majority of the time, prophylaxis.
Right, and I think with the recommendation for triple panel testing, a lot of times we're talking about the potential for future immunosuppression therapy in those individuals that you do the triple panel, they're found to be core positive, and the counseling that we provide is that if ever you will need chemotherapy or immunosuppression therapy, please make sure to check your hepatitis B status, because you may need antiviral therapy, or at the very least monitoring in the setting of immunosuppression. So this is, I think, a good question that we were discussing right before we started here. So do you recommend testing quantitative surface antigen at every visit? Do you test individuals at every visit in your practice?
And the answer is a resounding no. Okay, but I check it annually, just to see where it is. Now, we have an in-house quant surface antigen. We actually get an index. So we actually get it, but it's reflex, it's just done automatically. But for most people, I think that a quantitative level can be obtained annually. They're usually, in the natural history, in people who are clearing, it will come down some, but you don't see like year to year 1 log declines. I think checking the surface antigen annually, patients who are quite engaged in their care actually want to know. They like this. Just be prepared to answer questions, and for those of you who use electronic health records, you will get lots of queries when they first get a quantitative level about the meaning of this.
Right, and I think the updated guidance is pretty clear. We want them to clear surface antigen before we discuss discontinuing therapy, but there are those caveats listed, right? That if the patient is really pushing to consider stopping therapy, having a quantitative surface antigen of less than 100 is something that can provide some reassurance that maybe they'll do okay in the setting of discontinuing. So, go ahead.
I'll do one here. So how is normal ALT being defined? So many patients who get treated normalized ALT to below 30, ASLD guidance. So an ALT, so in general, especially in the era of metabolic liver disease, this is a very important question. The ASLD, they still use 25 and 35 as your cutoffs. Other guidances have used 25 and 33, but those are truly normal, healthy ALT levels that are not linked to liver-related outcomes. And I'll be the first to acknowledge that sometimes in somebody who has an intermediate level, and there was a nice question here about someone who might have a viral level that's lower, but an ALT that's higher with metabolic syndrome, and what do you do? And in some of those individuals, I try and address the metabolic factors, but I will tell you, in the new guidance, this is where shared decision-making becomes so helpful. And so I could envision that we would have individuals here where we will start, and I have done this before in a shared decision-making, in someone who is in the gray zone, I go ahead and offer those people treatment, but you try and intervene metabolically as well. But in the laboratories reference around the country, I'm in California, but we have reference labs at hospitals where the upper limit of ALT is 60.
Right, and we're like in the 40 to 50 range, which we try to teach our students and trainees that is not a normal ALT, even though it doesn't pop up as red in EPIC. And actually, another question.
We have a question
great.
here, please.
Yes, please.
Hi. In regards to the HCC screening in patients who have lost hepatitis B surface antigen, is that for patients who have undergone treatment and lost the antigen, or even those who have spontaneously cleared, should we still continue?
It is for both. So if you have cleared both spontaneously, and again, it doesn't, have you seen patients in your own practice that have cleared surface antigen spontaneously? Yeah, we tell them to purchase lotto tickets. They're very lucky. Right? They're very lucky when they do that. But again, a question that has been going on for years has been, who do you screen and who don't you screen? So, but again, for purposes of the guidance, it doesn't matter how it happens. It's just they use age, because there is a risk as you get older, if you clear surface antigen, of still having hepatocellular carcinoma. In the inpatient service, if you care for those individuals, you'll see people come in who are core positive, who wind up with substantial hepatocellular carcinomas. So it doesn't matter if it's treatment or spontaneous.
And that relates to our discussion about the HBV integration. So these people have had disease for a longer duration, and so they still have that HCC risk that is persisting, even despite surface antigen clearance, and that's why age is an important factor.
Thank you so much. Quick question in the same regard. So I should screen even patients who are core antibody positive, but they don't have the surface antigen?
If they are above, so if you have somebody who you're following, say a woman who's 55 to 60 years old, she clears surface antigen and is now core antibody positive, just as you said, because core persists lifelong, the answer is yes.
Great, thank you.
You have another question?
Yeah, so there's one actually that came in. So what would you recommend for a 50-year-old patient with HBV DNA? I guess they mean maybe low HBV DNA, but F2 fibrosis and diabetes. And I think that goes to your point about metabolic comorbidities. There's actually an abstract at this meeting by Lori Talep that looks at HBV DNA and metabolic comorbidities, not even looking specifically at steatotic liver disease, but in those individuals with certain metabolic comorbidities, they're at higher risk of HCC and decompensation. So I think to your point, that those are individuals that we really need to be a little bit more thoughtful about. But in this particular case, the fact that that person has F2 fibrosis and is over age 40, those are two of those factors that we mentioned that the current guidance is emphasizing as risk factors that you would consider initiating treatment, even with HBV DNA levels that may not meet your thresholds.
Yes, here's one 85-year-old e-antigen negative HBV viral load 783 and F3 fibrosis. So that's a tantalizing question. In this particular case, I would make sure it's F3. I would probably do not a biopsy, but I would do something else to make sure if it's F3. If they're F3, platelets a little bit low, I'm not opposed to putting those people on therapy. The guidance for the AASLD is that now patients with cirrhosis, compensated and decompensated, both should be on therapy regardless of the viral level. That's a subtle change from the prior guidance where it was compensated, undetected, you didn't necessarily have to treat, right? But now we treat anyone. I would be inclined to offer this person treatment, particularly just to prevent an outcome just at that age.
Yeah, I mean, the advanced fibrosis, is a concerning features, and I think I would agree in that case.
Okay.
All right. Well, I think we're...
we have one more, please.
Oh, we have
Last
another,
question.
okay.
Yeah, thanks.
Please.
One of our patients asked, she had an incidence where her viral load was already quite low, below 500 units pre-corona, but after corona it shot up. I'm just wondering if there's any significance to that, or...
COVID?
COVID?
Yeah, COVID.
She got a COVID infection? Is that what you're saying?
That's right, yeah. And it affected her viral load.
I don't know that there's great data about it, but as we've seen, hepatitis B is a very immunologic responsive virus. So could it be that something immunologically shifted with her COVID? But also people naturally spontaneously change their viral loads. And so that's why in these guidance, you don't stop monitoring them if their viral load is low. You do check every 3 to 6 months, and people can spontaneously. So I'm not sure in that setting if it was COVID related or not, but also this just happened spontaneously.
Was this a recent change?
Over the last 12 months. Yeah.
And it stayed different now?
It stayed elevated, yeah. And she's on one of the medications mentioned here.
Okay, so she's already on therapy. She's on therapy now.
That's right, yeah.
Yeah.
Oh.
Yeah, but her viral level now should be suppressed, right?
I think it's lower again, but not as low as pre-COVID. Yeah.
Was she on treatment before COVID?
That's right as well, yeah, for many years. Yeah.
So on treatment, she had a COVID infection and now her viral level is higher?
That's right. Yeah.
That is interesting.
Yes. Is she adherent?
We'll double check.
That would still be my first question. Yeah, it's unusual, right?
Yeah,
to get a viral load a viral breakthrough like that? Yeah.
Yeah.
Further investigation, I guess. Thank you.
Thank you.
All right,
Okay.
well, thank you everyone
Thank you,
so much
everybody.
for joining
Enjoy
us.
the rest of the meeting.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Train Learning Network. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/QKQ860.